Good afternoon, everyone. We are delighted to welcome you to our webinar this afternoon, an introduction to advanced care planning for health professionals. My name is Jasmine Palliative, Primary Care Project Manager at Western Victoria Primary Health Network, and I'll be your facilitator for this afternoon. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways from where we're all tuning in from today. I'm joining you this afternoon from beautiful Wadawurrung country. I'd like to pay my respects to elders past, present and emerging and extend that respect to any Aboriginal people in attendance today. Before we begin, just a little bit of housekeeping. This webinar will be recorded and you will be able to access the recording freely on the Western Victoria PHN Learn YouTube channel. We'll put the link to access our recorded webinar events into the chat. Following your attendance at this introductory webinar, if you have further interest in developing skills to facilitate advanced care planning, we will be sharing a link to a regional training calendar for Western Victoria. This calendar will be updated early in 2025 with scheduled dates for advanced care planning one-day facilitator workshops. A special mention to our upcoming Healthy Ageing Through Primary Care education dinners for GPs and practice managers in Warrnambool, Ocean Grove and Hamilton. This is also an opportunity to network and connect with colleagues with complimentary canapes and a sit-down meal available on the night. Registration link for this is also in the chat. You may be familiar with Health Pathways, the free online resource with localised clinical and referral information for health practitioners. You will see on the slide here some of the advanced care planning related pathways available. Western Victoria PHN will provide a certificate of attendance for this webinar. Please take a moment now to check that your full name is displayed accurately on your screen. If not, or if you're unsure, please rename yourself or type your first and last name into the chat box now. This will ensure we can issue you with a certificate of attendance. This event is being recorded. Please keep yourself on mute unless you would like to ask a question during the designated Q&A time at the end of the formal presentation. We do encourage interactivity and discussions. Please feel free to type questions into the chat box at any time, and I'll ask them on your behalf to our presenter at the end. Finally, there is a link in the chat box to complete the survey after the webinar, and we'll show this slide again at the end of the presentation. Now, I'd like to introduce our presenter for today's webinar, Melissa Couch. Mel is the Advanced Care Planning Consultant and Clinical Nurse Consultant for Community Palliative Care at Southwest Healthcare in Warrnambool. I'll hand it over to you now, Mel. Thank you.
Thanks, Jazz. Thanks to the PHN for allowing me to do this today. It's a really great opportunity, and thanks for everyone who's joining us online. So some of the outcomes today, firstly, what is advanced care planning? Trying to identify opportunities for triggers for conversations in routine practice, wherever that might be, GP, inpatient, community, wherever advanced care planning discussions might occur. We'll look at some of the legal and ethical implications of advanced care planning, including advanced care directives and how we utilise them in the healthcare setting, and hopefully increase people's ability to have these conversations and ultimately complete advanced care directives with other consumers within our organisations. So what we're looking at today is advanced care planning done in Victoria. There are other legislation requirements around Australia. So today, obviously, we're looking at Victorian advanced care planning and also some of the resources that are available to us. So what is advanced care planning? It's really just the process of planning for future where a person's values are made known in the event that that person lacks capacity to make their own decisions. It can be a fluctuating time. It might be reversible, or it might be something that we foresee is going to be a ongoing and cognitive decline, such as something like dementia. So it's really important for us who work in healthcare to understand what makes someone individual, and advanced care planning through an advanced care directive really allows an individual to express what their personal values and beliefs are, and especially around ongoing medical treatment. So we're just going to watch a little video here. It's a really great opportunity to get a basic understanding of advanced care planning.
My name is Diana, and Roy and I are husband and wife.
My name is Anita, and John is my dad.
My name's John. I'm Quivy's husband.
So Roy gets to go on a trip of a lifetime. Where does he want to go?
I'd say Bora Bora.
No, I definitely want to go with Bora Bora.
What food could Anita not live without?
Probably curry.
Anything Asian?
He couldn't live without a lot of food.
And what about you? What food could you not live without?
Probably fruit in general.
Probably chocolate.
Just true.
Well, Anita asking me, so what's this about? I said, I don't know.
If you can think about a moment where you pushed through a hard time together, can you describe that?
At school, when she was being bullied, we had to see some counselling.
Just talking me through it and helping me get through it. Kind words and lots of hugs.
For me, it was probably the time when we were first trying to have our first child, I guess. We went through IVF and things like that. Becoming parents is something that we all hoped would come naturally, but it didn't to us initially, and we worked through that together.
Roy's hurt in a car accident. He needs a breathing tube for the rest of his life, and he'll never speak again. Would you consent to this?
Well, yeah, I would, yeah.
No, I wouldn't. Definitely not. I don't think I would want to burden anyone with that. So I'd rather not. Yeah.
Anita had 3 months to live. Treatment would give her an extra 2 months, but she would never see outside of a hospital. Would you consent to treatment?
Yes, this was a difficult one. This one, 2 months, it's just 1 week, 2 months, any time.
Not at all. No.
That's unexpected.
I don't want to be kept in a hospital for forever.
John has had a massive stroke. Does he want a feeding tube to keep him alive, even though he'll never talk again?
No.
No, I don't. It's very important to me to be happy and functional in my life. No, I wouldn't want that to happen.
Roy's in the last stages of terminal cancer and his heart stopped. Does he want CPR?
Probably not. I don't think you would, no, I don't know.
So how do you both feel after answering those questions, and why?
It felt quite confronting in a way. But
You think about it and you talk about it just very lightheartedly, but I don't think anyone really puts a lot of thought and serious thought into it.
no.
Why do you think that some couples don't talk about this?
It's not a pleasant subject. I mean, nobody wants to dwell on the fact that they're going to die one day, and possibly in adverse or difficult circumstances.
So if I was to tell you that advanced care planning is essentially a conversation that helps your loved ones know what medical treatment to choose for you if you had a sudden event, what would you think about it now?
I think it's a great idea.
Yeah, absolutely.
It's important, not just for yourself, but more so for your family, I think.
Definitely have to have a bit more of a talk. And it's not just about the two of us. We also have kids and all that kind of stuff. Yeah. So there is a bit we need to consider. Yeah, 100%.
So I think that's a really beautiful introduction to some of the common things that come up in advanced care planning when we're dealing with clients and patients. And it also shows this is genuine reflections, and this is from my experience, that a lot of people aren't having these conversations. We're often leaving the conversations way too late in someone's journey, or they might pop up under acute and very stressful circumstances. And I always joke, we put lots of effort and planning into buying caravans and houses and cars and things like that. And yet we don't put much effort into planning for inevitably what will happen to 100% of us, which is, eventually we will die, or we may have some quite significant medical events. So as it was presented in that video, really in a nutshell, advanced care planning is planning for someone when they're unable to communicate accurately their preferences for medical care. So some of the things that are involved in advanced care planning are, do they have existing advanced care planning documents, and who is their medical treatment decision maker? We need to really put a lot of focus, I think, on getting the information out to clients and families about the importance of the medical treatment decision-making role, because that person does have a huge impact on how their loved ones' medical outcomes may be affected. And then also completing an advanced care directive, whereby we can actually get insight into that individual's specific values and preferences for their care. So advanced care planning, as I mentioned before, is across Australia. So the video that we just watched is accessible on the Advanced Care Planning Australia site. So at present, all Australians can write their values and wishes in an advanced care directive, and they can also appoint a substitute decision maker. But just be aware, there are differing state legislations and sometimes some different terminology. So the benefits of advanced care planning, I'm a little bit biased. I think there's many, but some of them are obviously with the person. It helps ensure that that person receives the care that is consistent with their values, beliefs, and preferences. For the substitute decision maker, and this is a huge one, I get a lot of referrals from people who have had to be a substitute decision maker and had never really had a conversation about what that loved one wanted, and it caused a lot of anxiety for those people. So by having a substitute decision maker involved in the process, it reduces the anxiety and burden for that person, because if they've had a conversation with their loved one, they are better able to make decisions that that person would have made themselves. And then obviously for healthcare professionals, we may never have met someone who comes into our service. So we can't be sure about what makes them who they are and what makes them tick as a person. So by having an advanced care directive, it helps us to understand what is important to that person in living a great quality of life. And obviously for the health service, it reduces non-beneficial transfers sometimes to acute care, and also by not offering unwanted interventions, which can quite often be quite stressful. Especially over COVID, we realised, sometimes we were taken away from our families for extended periods in other areas and we weren't seeing our loved ones. So, if we can try and keep care that is consistent with a person's wishes and where they need that care to happen, that's good outcomes for everyone. So making medical treatment decisions, health professionals do decide which treatments are indicated, and that should be discussed with the person. And, you know, it's a real thing that even if a person lacks capacity for whatever reason and to what level, we should always involve the person in decision making. So health practitioners are not required to offer or administer non-beneficial medical treatment. So we can't be forced in the healthcare industry to be providing treatments that will have no medical benefit. So that might include something like CPR on a quite significant aged person. They might be 95 with lots of different comorbidities, you know, so we have to look at, well, okay, what would be the benefit of providing CPR in that scenario, and are they looking at having a good quality of life out after that? So if a person has capacity, they make their own medical decisions. We only defer to a medical decision maker if the person has not got capacity to make that decision. So capacity, we presume that all people who are adults over the age of 18 have capacity, and to ensure that we can look at what determines capacity, there's a set of criteria. So to determine someone's level of capacity, we like to make sure that they are able to understand the information about the treatment and procedure that's being proposed or offered, that they can remember the information long enough to make a decision about that proposed treatment, that they're able to understand, weigh up the pros and cons or the risks and the benefits of that said treatment or procedure. And then they must be able to also communicate their decision. So if we felt that someone did not have these aspects of capacity, then we refer to a medical treatment decision maker for an outcome. So some of the conversation triggers when we might start looking at someone and starting to really highly recommend advanced care planning on patient request. In GP world, it tends to come up on a 75 Health Plus assessment that's undertaken in GP offices. If there's a significant change in life circumstances, so that might be that you've had a death of a spouse who was your previous medical treatment decision maker. It could mean that you're entering into an aged care facility. It might be a discharge from hospital whereby goals of care have been discussed and there's been limitation to a person's goals of care. They might have declined, they may have been diagnosed with a new terminal illness or some sort of chronic illness. So as I said, diagnosis of a new chronic or terminal medical condition is part of a chronic disease management plan. And definitely anyone who is at risk of losing capacity within the next 12 months. To undertake legal advanced care planning, we do have to ascertain that the person has capacity at the time of doing that. After that, if a person is deemed not to have capacity, we are unable to then go on and appoint legal documents as such, as I said, to proposed admission to a residential aged care facility. My opinion is I think we should be having this with all people over the age of 18. You know, there's lots of incidents whereby young people are faced with potential car accidents, injuries through sport. So it's really important that at the very start, we always start promoting people, that they start looking about who their medical treatment decision maker might be. So the advanced care planning conversation process, you know, we should be just introducing the topic. Generally, when I go and see someone, I only spend 5 or 10 minutes and just briefly go through it and how that might be of value to that person. I start to really focus on who is the right person to speak for that person. And sometimes we find that the person's loved one, spouse, partner sometimes can be too close to that person, and it's hard to remain objective because at the end of the day we're asking for a medical treatment decision maker to make a substitute decision. So we're asking them to stand in that person's shoes. We're not asking for their opinion on what they think's the right thing to do. We want them to really put themselves in that person's shoes and make a decision that they feel that person would have wanted for themselves. And then we start to look at discussing goals, values, and beliefs, and what are we wanting from that, and the care and treatment for medical preferences. So sometimes it is a bit easier to do it if we know that they have a terminal or quite significant comorbidity. we can start looking at, when do we look at withdrawing treatment? What does that look like? What does end of life care look like? Is that something that we would like to try and facilitate in someone's home? Or is it that we might need to arrange for you to come into hospital for your end of life care? And then how do we conclude it? Often that's hard. We're all playing bits and pieces of this role. But, how do we then close the gap on advanced care planning conversations? Who's going to follow it up and where do we go from there? So some practical tips on having the conversation. It's really about finding out what's important to that person. I often ask people, what's a good day? What drives you to get out of bed today? What do you love doing? What are some of your hobbies? Because that tends to play into what the person values. It might be that they very much value living a very active lifestyle, that they love socializing and communicating, and that then can have implications for medical adverse outcomes. So we have to see how do the two align and what does it look like for that person when we've reached our line in the sand, as I like to say to patients. Have people got things on a bucket list? Would they accept certain treatments just to get to a milestone birthday or birth of a child or Christmas, things like that? What are they prepared to compromise on in order to get something ticked off or get to a certain date? So what matters to that person? I often break things down to people. I try to sometimes stay away from medical jargon because it confuses people. What would be acceptable to you? So I break it down into the thinking, talking, eating, and walking. And most people, if we ask them about where their line in the sand is with thinking, in using their brain, they're actually quite able to communicate where that line in the sand is. And it's also about talking, eating, mobility. Where is someone's line in the sand with their mobility and an ability to walk and or not walk? So storage of advanced care documents. Here at our hospital, we have a very clear process for putting people's advanced care plans. So it's important that we also educate people on the importance of sharing their documents. A lot of people do powers of attorney, appointments of medical treatment decision maker with lawyers, and it's not very handy if that has been left at the lawyers and then not transported or given to the hospital, whereby most of these occurrences will play out. So we need to make sure that we are giving people the opportunity to provide their advanced care planning documents, that they're current, accurate, and that they're up to date. So we should be always reviewing what we have on file, and then making sure that our systems that we work with are able to record who is a person's substitute decision maker, who's important in their life, where is their advanced care directive, and how do we access that. So the law in Victoria is based on the Medical Treatment Planning and Decision Act. This covers all aspects of advanced care planning. So in Victoria, we can legally choose and appoint a medical treatment decision maker, and we can also make an advanced care directive. So there's two components to that. There is a values and or an instructional, and we can also appoint a support person. So what are a health practitioner's responsibilities around advanced care planning? So in Victoria, all registered health practitioners are obliged to make reasonable efforts to determine if a person without capacity has an advanced care directive. So that's why it's really important that hospitals have systems in place that they can store these documents and that they're easily accessible. So an example of this is a patient comes in, they've had a cardiac arrest out in the community, brought in by the ambulance. We need to, straight from ED, as soon as they come in those doors, be able to identify, one, do we have existence of advanced care directive on our files, and to ascertain who is the right person if in the event that the person was unconscious, for example, have we got their details up to date about who their substitute or medical treatment decision maker is. So we can also provide information about advanced care planning, and there's some really good resources online. And we need to be able to encourage discussions and record these conversations. So as health professionals, I think, we find quite often sometimes we're the barrier to having these discussions. Sometimes we might be scared to bring it up to a patient, that we might upset them. And quite often patients are actually wanting us to bring it up because they're often hard conversations to have with their loved ones. So sometimes we can be the person who facilitates these conversations with the person and their loved ones to get them to have open, honest conversations. Then we need to look at identifying the right medical treatment decision maker and have a look at what documents. So sometimes we have documents that have been on our file for 20 years. The patient may not have been a huge user of a service. So it's important that we get them to have a look at the existing documents and see whether they reflect their current health conditions and their preferences for care. So a medical treatment decision maker role, it's a huge role. And this is one thing I really try to focus on with people I'm dealing with, is getting the medical treatment decision maker role correct, and also having the medical treatment decision maker involved. It's really important that they are able to openly ask questions to the person that they're expected to have make substitute decisions on. So all of us generally will have one, and we'll go through a bit later about how we determine who that person is if there's not one being appointed. But the medical treatment decision maker must make a decision that they believe the person would have made themselves. As I said before, it's standing in their shoes. They may be appointed to the role formally by that person. They are required to accept the responsibility of this role, and only one person can act in this role at any time. I'll often have families who will try, they'll try and say, I'd like to appoint all my 4 children. I always make it very clear that only one person acts in that role at any one time, and it's the person who is listed as 1. It's then advisable that that person who is the medical decision maker then goes and disseminates that information to the rest of the family for them to have an impact. But healthcare practitioners are obliged to go to that one person who's been determined as the medical treatment decision maker 1. Or they may be identified via the legislation if we can't determine who someone's decision maker might be. So this is what we use as a guide. It's under the medical treatment decision-making law. That first, if we have an appointed medical treatment decision maker, they go above everyone else. This still includes someone who you may have done earlier, before 2018. You might have an enduring medical power of attorney. That's what it used to be called. Those are still legal, but I often use that as a good opportunity to have another discussion about have needs changed. It might be an aging couple who sometimes I try and look at, is there a better option? Quite often when people are quite elderly, they're starting to have cognition issues. So I might start looking at appointing a new medical treatment decision maker. So they trump everyone. And then we have a guardian appointed by VCAT. They are second under there. And then if we don't have any legal appointments, just imagine there's a line between 2 and 3. We go to the first of the following. Now, there's a whole big expansion of who this could be determined. And it's someone who is in a close and continuing relationship with that person. They don't have to live with the person sometimes, but they have to be over 18 and they have to be able to understand complex medical decisions and have capacity themselves. So it goes to a spouse or domestic partner. Sometimes people get a little bit scared when I say that could be a young couple who are in a newish relationship of potentially 6 months, and they might not even live together, but they could also be counted as that person's domestic partner. You don't actually have to live with the person. You just have to have an inferred close and continuing relationship, and there's no time frame on determining that relationship. Then we go to a primary carer, so that's unpaid. It's not any of us who are working as, health professionals. This might be a mum or dad who's caring for their adult child who might have a disability of some description. Then we go to adult child, and if we can't determine who it is and there's multiple children, we go from the oldest to the youngest, and it's the same. Then we go down to the parent and then adult sibling. So it's important to note that we don't include step children in any of these scenarios, and it's also, there's no friends. So if you had someone outside of these descriptions, then it's definitely worth looking at appointing a legal medical treatment decision maker. So medical treatment decision makers and the facts. They must make the decision that they reasonably believe is the one that that person would have made themselves. Any substitute decision maker can consent or refuse treatment on behalf of the person who has lost capacity, and they must be reasonably available, willing and able to make those treatment decisions. So I often say to people, you know, it's fine that we prefer that they are living locally to the person, but if their substitute decision maker lives in another state or even another country, I always just make sure, have they got a mobile? Are they likely to answer that mobile? Because if it's someone who's working, say, offshore, in a fly in, fly out, and they may not have access to their mobile for 12 hours a day, every day for 7 or 10 days, that person might not be the most appropriate person to be the MTDM. So with the documentation, the forms must be completed in English. We can offer interpreter services, which must be used through a validated interpreter service. And there are also translation resources and other resources in other languages. MTDM appointment forms must be witnessed by 2 adults, and one of these must be a medical practitioner or someone able to sign off affidavits. Now, the second witness could be a practice nurse, it could be me in my role, but it can't be the person who has been appointed as the medical treatment decision maker. So there's no number or limit to the amount of decision makers that can be appointed. However, it's mindful to keep or let the family know that there is an order. So we only ever revert to 2, 3 or 4 when one's not available and so on. So all these supporting documents and resources can be found on Advanced Care Planning Australia's website. So a note on next of kin, some places are still using this as a term. The next of kin term was utilised in healthcare previously. However, it does not have any legal context or meaning in relation to advanced care planning. So it's a term that we're moving away from, and we should be using the term medical treatment decision maker. So the person who can speak on behalf of someone who does not have capacity in Victoria is called a medical treatment decision maker. It's also interchangeable with the generic term substitute decision maker, which is an Australia-wide term. So this is what an advanced care directive looks like. As I said before, there's 2 components to that. So the 2 key components are the values directive. So this helps guide your decision maker and healthcare professionals in making decisions. So we use it as a third of the picture. We look at what the situation is for the person who's lost capacity. We look at what treatment options may be available to that person, guided by your healthcare practitioner. And then we think about what we know about the person, and quite often we gain that information from what's written in their values component of their directive. And then we also ask and include the medical treatment decision maker. We highly rely on their openness to guide decision making and giving input into what that person would have made if they were able to make the decision for themselves. So the standard forms are pretty easy to go through. It's, you know, we need to make sure that they're legible, that there's relevant and up-to-date birth dates, contact details, especially the phone numbers. I always like to, when I'm writing about their major health problems, I try and generally put a time frame next to that. Was that something that happened 20 years ago, or is this something that's occurred more recently? And then we have the instructional directive. So this is a legally binding instruction that is specifically meant for the doctor. So what we talk about in that is clear medical binding instructions. So we have a consent and a refusal. So for instance, it might say, I consent to IV or oral antibiotics and blood products, but I do not consent, I refuse resuscitation, being on a ventilator, further chemotherapy. So they're very specific instructions that are aimed at the doctor caring for that patient. So the instructional directive must be followed. It is legally binding. Doctors don't have to go and discuss that with the medical treatment decision maker. They are obliged to follow that. So an example of that is the person who presents to ED, they've had a massive heart attack. We find on our advanced care directive that's held on file, within that instructional directive, they have refused CPR. So we must follow that instructional directive, and then we might look at a palliative approach and making that person comfortable. So the facts, the Advanced Care Directive, it can only be completed by a person who is deemed to have capacity. The forms must be written in English and easily understood, and they must be witnessed by the 2 adults. Now, for an Advanced Care Directive, one of these witnesses must be a medical practitioner. So we're hoping that by getting a medical practitioner involved and in the witnessing, that the person's had these statements or their preferences explained clearly and what that might look like, and does the person understand what it is that they're actually writing about. With the values, it's really the audience is the medical treatment decision maker. So we're giving them a guideline about what's important to them in living a good life. So a lot of people would put their main focus on what they value is the ability to use their mind. Most people, I would say 90% of people, value the ability to use their mind and have cognition and input into thought and thinking and emotions. So it's important to then narrow down when you're helping someone to complete that document, what is that specifically meaning to them? So with the instructional directive, as we said, it is legally binding and we must support and follow that direction. So capacity, when someone has lost capacity, we still do have options on how to record preferences for care. If we didn't have a previous written Advanced Care Directive, we can complete on behalf of the person who has lost capacity what I understand to be the person's preferences and values. So this can be completed by the MTDM with family and friends and or carers. So as it says there, it draws on the personal beliefs of that person, what we know about that person, and it doesn't have to go through the formal witnessing process, but at least we have a bit of a guiding document to caregivers. And quite often this will play out in an aged care facility where the person's already come to the facility and they've already deemed to have lost capacity. So it gives us a framework for which we can go forward in developing treatment plans for that person. So we have a support person role. This was newly introduced under the Act back in 2018, sorry. So the support person can be appointed. You can only ever have one of these people appointed at any one time. The form looks very similar to appointing a medical treatment decision maker. We're appointing a person who, the person who has decision-making capacity to make their own medical care decisions just sometimes might want someone involved or another contact to help them interpret some of the information. They're authorised to access a certain amount of health information. That might be a niece or a granddaughter who is helping Nana go to the GP. Sometimes they get a little bit forgetful about what the medication is that they're being prescribed or upcoming appointments. So you might appoint that support person to be able to go along to those appointments and that they can have a certain amount of health access information, because obviously we're bound by consent laws. So from a healthcare perspective, we have to be really mindful about who we're giving out information to. You know, the first gold star, I guess, is that the person with capacity always is giving out the information unless they consent to the sharing of information. And then it comes back to if someone's ringing about information about a client or a person, the only person we really should be giving information to is the substitute decision maker. So as we said, the support person can access or help access health information relevant to that medical treatment only. So they can't go back and find out a person's whole health history. They can, they don't have the power to make medical decisions on behalf of another person, but they can also be appointed as the MTDM over the time. And you can only ever have a person in that role at any one time, whereas the MTDM you can appoint and get a long form and appoint multiple people. Once again, they must be in English and witnessed appropriately by the 2 adults, one being a medical practitioner, and they must also be able to have an affidavit. So all these resources are available on the ACPA website. So we're coming to the end of today's question, or coming up for questions. So hopefully we'll get to have a fair bit of chat. I'm open for anyone to, I'll stop sharing my slides. Hopefully there's lots of discussion out there, because usually after we have, I do these presentations, some people's brains get ticking about, wow, how is, look at your own circumstances and your own individual roles that you might be a substitute decision maker. Are you in a relationship, and have you ever had these conversations with your loved ones and family and friends, and have you thought about clearly, is the person that you're potentially has been appointed, or is that person as determined, are they the right person? So I'd love if anyone has any conversation starters or questions.
Thanks so much, Mel. We do have a question in the chat. It says, can RNs, ENs witness Victorian advanced care directives in residential aged care?
So it depends on the individual organisation. So say at our organisation, we have a very clear policy around witnessing. So we have made a decision that only people who have attended, I run full day workshops on how to complete and undertake advanced care planning. In our organisation, you're only able to be a second witness within a health providing aspect if you've done that course, because we want to ensure that people who are signing off on this understand the legal ramifications of what you're signing off. So when you fill out these forms, you are actually witnessing that you attest that the person who is completing the document has capacity. So you need to understand concepts around capacity. You need to know, do they have capacity? Or are they being coerced by someone to fill out the document? So that's, and as I said, that's an individual organisation should be looking at how they do that and have some clear guidelines or policies around that. But technically you could.
Excellent, thanks,
Short
Mel.
answer.
Another question, when should revocation paperwork be completed?
So yes, there's when all the new forms come out, there are revocation forms. So that could be completed by either the person who has appointed someone. So it might be me, I've appointed my sister and we've had a fallout, which we haven't. But I might say, we're not in contact anymore. I fill out the revocation form and then I make that available. So it withdraws her power to be my substitute decision maker. On the same token, someone who has been previously appointed as a medical treatment decision maker can also complete to say that they no longer want to be that person.
Excellent, thanks, Mel. Alison, Ryan, I know you've had a few comments in the chat. I'm not sure if you want to take yourself off mute just to clarify, because I think we jumped ahead from your question.
Sorry, I was trying to type as fast as I could and I hit the enter button and it
That's
popped
okay.
up. So at the moment, we're using the advanced care plan for a person with insufficient decision-making capacity, which I got off the Advanced Care Planning Australia website. Is the document that Mel discussed a preferable document, or is the one that we're using okay?
So the one that I listed on file is one that's been determined by some high-level people who are in advanced care planning. So you can use other forms because it's not being witnessed the same as an advanced care directive. So we don't have to meet the exact same witnessing requirements. We just promote the form that I used before, that I mentioned before, because it's been a validated tool. I think it was done at the Northern Health. It was originally developed through there, through Barbara Hayes, who's heavily involved in advanced care planning. And it kind of meets similar wording that's used in an advanced care directive. So it's not to say, because don't forget, if we could write our wishes on a piece of paper. They don't have to be witnessed. So it just means that they don't have any legal weighting, I guess, is the thing to think about. It's more about that values. What do we know about that person? So if you've got that off a validated website like Advanced Care Planning Australia, you would be fine to use it.
Okay.
Sorry, I was just going to add that I do make families aware that it is not a legal binding document, but that we will uphold their wishes within the document.
Yeah. And sometimes that's really good for that document to guide decision-making around goals of care. So we utilise, and it's got different terms within organisations, but here at our organisation, we use what we term as a resuscitation plan. So everyone who enters our service over a 24-hour period, we use that document to determine their goals of care. So that might be that in discussion with either the patient and or the decision maker, that the person might be goal A and they're for full resuscitation, they're for all interventions. Then it might be we drop back to B, the person has multiple comorbidities, they might have a life-limiting illness, so they might have limitations to care. So sometimes it's really good to have those forms also in aged care as well, because not everyone has an advanced care directive. So we can still, so a goals of care or resuscitation plan is a medically driven document, but it's helpful to help guide decision making. So then we can use those for the person lacking competency forms to help determine the outcome of resus plans or goals of care forms.
Okay, there's a mini case study in the chat. So I had a situation today where a resident that has full capacity was unable to sign documents at the bank. Then they went to the lawyer and got a copy of the medical treatment decision maker form, and the bank allowed for the MTDM to sign without the patient there. Is this okay?
No. So we have to be very clear that when we get presented documents, they must specifically be appointed medical treatment decision maker, or they could still be an enduring power of attorney for medical purposes. That is a very distinct document and person to an appointed financial or an enduring power of attorney financial, and then we have an enduring power of attorney financial, and it also can be for personal matters. They are very distinct documents and paperwork. So someone who has a financial power of attorney for a client, if they're not the medical treatment decision maker, if we have another person who's been appointed, they can't use that form, and vice versa for making financial decisions if you're a medical power of attorney. It might be feasible to believe that the person might be the same, but they need to provide the financial power of attorney.
Okay, another question in the chat. If people have started filling in a form via PDF, can the form be completed handwritten? Is that a legal document? So I'm presuming that part of it's been completed electronic, some of it's been handwritten. And there's a follow-up question. If a patient or medical power of attorney has changed address, should a new doc be completed?
You would suggest that you update the form, and then there's no room for legal conflict, I guess. And that's why we suggest when people come in, we always review the forms that they've got. So if someone has old details, then I will very much highly encourage them to change all those details. The first part of that question was,
if it's handwritten and electronically completed, can they be together? Is that okay?
We've done that where we've had different people fill them out. I might have started, the doctors started, they might have started writing it out. So long as, because we've got to remember, we're getting it witnessed with that person, with the doctor. So regardless of whether it was handwritten or both, we're getting that document once it's completed, witnessed by the doctor and the person that's present. Obviously, it would be best that it was all done by the same person, but quite often I'll start a document and I'll do all the values part, and then the GP will follow up and do the instructional. So there's two sets of handwriting that's different.
Another question. What is the difference between a medical treatment decision maker and medical power of attorney? Are they different forms that are required to be completed? And then someone else has put a similar question: is medical power of attorney replaced by medical treatment decision maker?
Yes, so medical power of attorney or medical appointed medical treatment decision maker is the gold standard, which is the legal document. So that's a legal document, and that goes above everyone. So for me, I have a legal document appointing my sister, she goes above everyone. Everyone here pretty much will have MTDM, a medical treatment decision maker. So they're either appointed or they've been listed by the person themselves, or we've appointed them via the legislation, which we went through before. So that's where we start at that step at the top, where if we didn't know who it would be the spouse or domestic partner. They're presumed as the highest ranking MTDM if there's no evidence of a legal document. Legal documents always trump everyone. And then think about, for anyone who doesn't have a legal appointment, whether it's a VCAT or an appointed document, then we go to a medical treatment decision maker. So you're either appointed or you're not. But they still have exactly the same role to play. But I guess the message is I really advocate that everyone should appoint one, because then there's no misunderstanding or misinterpretation. So we'll often see a lot of family conflict come out. And, you know, it becomes quite messy when we're relying on who we think is the most appropriate person to be the MTDM. If we can't determine that, then we go by the legislation and the ranking and the hierarchy. It does sound a bit confusing sometimes with the terminology. You're either appointed and it's legal, or you're MTDM and it's been determined by the person, but there's no legal authority that's been written.
Excellent. So we've got no more questions in the chat, but thank you everyone for being so active in asking your questions. I know that Mel really appreciates it as well. So please take the time to complete the participant evaluation survey. So via the QR code on the screen or in the link in the chat. And again, just thank you so much to Mel for sharing your time and expertise with us all. We really appreciate your contribution to supporting advanced care planning in our region. So thank you to all of our attendees for your time this afternoon. Thank you, everyone, and enjoy your afternoon.
Thanks, guys.